to speak about maternal mental health. This is Maternal Mental Health Week, as we're going into the official Maternal Mental Health Week, which is the first week of May. And we're doing a kickoff dedicated to that through the Maternal Mental Health Leadership Alliance, which is hosting this event, and we're excited for those of you that are joining us live. We want to be able to share information to anyone who is interested in this space of maternal mental health, which is prevalent and common and treatable, and all the good things we're going to speak about here today. I'd like to say those folks that have comments, please send them live on the Facebook feed. We can take breaks and answer those as well. And our panel here, of whom I will introduce momentarily. Hashtag MMHLA, hashtag maternal mental health, hashtag maternal mental health week, and hashtag MMH is always good, and that's maternal mental health. And I, as the executive director of the Maternal Mental Health Leadership Alliance, am really dedicated with the verbiage around this. We chose maternal mental health because it really is a range of, just like autism. Autism is a spectrum. We have perinatal complications, and those are also a spectrum. It's generally conveyed as postpartum depression, but I know from my own self that experience did not interpret into depression. So again, thank you to the panel we have this morning. We have Valerie Plain Wilson, former CIA officer and board member of Postpartum Support Virginia, who also has lived experience. And I always liken my lived experience to the reason why we do sleep deprivation during times of war is exactly what mothers go through by choice. We have Lisa Tremaine, the president and co-founder and board chair of the Bloom Foundation for Maternal Wellness, and she'll be speaking about the Founders Health program in Jersey. And we also have Dr. Tiffany Fascione, who is the acting director of the Division of Psychiatry Products at the Food and Drug Administration, whom I'm personally and professionally thrilled to have here, as we have the first ever treatment for postpartum depression, and she'll speak more about the intricacies of that. I generally feel that once we have a medicine for something, now society can take it seriously. So a little bit about the Maternal Mental Health Leadership Alliance. We're a nonpartisan 501c3 nonprofit, and our goal is to promote the mental health of childbearing women in the United States by advocating for universal education, screening, referral, and treatment of postpartum depression and the related maternal mental health challenges. These are temporary and treatable conditions that can be screened ahead of time. We can talk about things like adverse childhood experiences, prior trauma, birth trauma, etc., etc. These are identifiable. They are also the number one complication of during the perinatal period, meaning during pregnancy and post, that can be identified with screenings. And we should be working with our healthcare providers to be discussing this. I have to emphasize, discuss it during, leading up to, thinking about becoming pregnant, during the pregnancy and after, not something that is an issue that is addressed on a sheet of paper after you had your child 6 weeks later. That's not how we should be addressing this. And this is an easy win for healthcare providers for taking care of women. Again, going back to the Maternal Mental Health Leadership Alliance vision, we again want to make sure that all childbearing women, so 18 to 45, but we also want to make sure that the grandparents, that the partners, that the family's aware of this information, because the worst case scenario that we see with undiagnosed postpartum depression are complications with the family dynamic and the baby and mom dyad, that relationship and the effect on the child. And we've even had information showing health implications and behavioral health implications to the child if we don't take care of the mom. I always think of what the flight attendant says on the airplane. If in case of emergency we lose oxygen, put the mask on yourself before you're going to put it on anyone else. And that hit home very much for me. I can speak to this issue as an executive director of MMHLA. I can also speak to it as a mom who honestly wasn't sure what happened to who I was. I turned into a former shell of myself during this experience of postpartum. I remember looking at my week-old and thinking that she thought I was a fraud. I mean, she's 9 now. I can get maybe she thinks mom's a little wacky, but not at a week-old. But those were thoughts in my own head that didn't make sense, and that if I just went to sleep and closed my eyes and disappeared, she would have been much better off. And that, to me, was a sign something wasn't right. And I want to say that when I went to find assistance for this issue in my own space, it literally was like finding a gnome under a tree. I'll liken it to an Atari game in the 80s where you were trying to fight off warriors or meteors and eventually be able to find the secret trophy. And we shouldn't be treating perinatal mental health like this, especially when we're talking about this being the #1 complication. Again, if anyone's watching on the Facebook Live, please feel free to send us commentary as well as questions we'll be able to answer. We were thrilled to be able to get information through Mathematica, which is a data-driven company that takes a look at an issue and then supplies data points and information. In this particular one that they did this on, the data points and information was on the societal costs of untreated perinatal mood and anxiety disorders. This was a report, a publication that came out on April 29th, and it had a panel of folks that took a look at a ton of different, many different factors that affect the family unit, the mom, society, etc. We always want to take a look at things in black and white terms with data, especially with dollars. We as a society seem to value dollars a little bit more than we value the actual issues itself. And I say that because I think that we have had a common theme across the national landscape on cost figures as opposed to actually serving the population of individuals that need assistance. And the incredible analysis and conclusion that came out of this societal cost of untreated perinatal mood and anxiety disorders for cost figure was a whopping $14.2 billion for all births in 2017, when following the mother-child pair from pregnancy through 5 years postpartum. Again, PMADs are the #1 complication of pregnancy and childbirth. Untreated PMADs, and that's perinatal mood anxiety disorder, are costly and have multi-generational consequences, which we will speak about here today. And half of perinatal women with a diagnosis of depression do not get the treatment that they need. And that is whether it is being able to openly discuss what the issue is. Again, this is #1 complication of all pregnancy. Being able to obtain pharmaceutical options if that is something that the individual does seek, because we have found through science, which is hard fact science, that there is a biological composition to the depletion of hormones and the change in body chemistry that goes along with this change in the biosphere of the mom. I always say that just because the neck separates the head to the body doesn't mean that we're not one holistic person. And I never looked at myself, nor do I think this panel here looked at themselves as just a vessel to bring another human being into the world, that we actually are continued to be our individual selves and need to be taken care of wholly with treatment. And we currently aren't speaking about it in working with our healthcare providers to the full capacity in addressing this. And this is an issue that we've seen the United States Preventative Services Task Force speak about. Medicaid has come out and spoken about it. The reason why we're here in this room today in the Capitol is the fierce mom warrior, Catherine Clark, Congresswoman from the 5th District in Massachusetts, who's actually at Tufts this morning with the speaker speaking about the need for child care options. And that's something that will also alleviate mental health complications when you know that your baby's going to be safe and your family will be safe. And that's another panel for another time, but I think it does play into this, and we have seen the continued discussion around the need to support moms. I don't want to get all into that Netflix show where they're all wearing the red outfits. What is it called? The Handmaid's Tale. Okay? Handmaid's Tale. And my point with that is that all of us are born from a woman. And whether you choose to bring a child into this world or not, we need to support the health and wellness of moms, because as best as I understand, and I'm being, it's right around 9 o'clock on May 3rd, I'm pretty sure we're still the only ones that are giving birth. So I think that we need to really focus on the support structures and needs for the family to be successful, because we are making a societal contribution when we bring a child into this world, and we need to set up families for success. And not everyone has a partner, not everyone has family members to assist. And so we really need to take a look, again, at that $14.2 billion price tag. Do we set families up for a fraction of those costs so that we have a healthy child, we have a healthy family, and we have a healthy mom? Or do we allow continual admissions into the ER and loss of work and running out of short-term disability and potentially being laid off and not able to take care of your child and all these other issues, in behavioral health issues in the academic setting for the child, et cetera, et cetera. So again, Mathematica put out this report. I think it's incredibly informative, and it was in partnership with the Perigee Foundation and the Vizoma Foundation, and it truly does outline productivity loss, health expenditures, traumatic birth deliveries, as well as suicide. When we're speaking about maternal mortality, we have to acknowledge the fact that suicide is part of that figure. It is hemorrhage, it is preeclampsia, it is not listening to women, it is definitely not listening to women of color, it is racial undertones of racial disparities, and it is also women seeking treatment and not being able to find that treatment, or being dismissed. Again, we're all hysterical. Being dismissed for our real understanding of our own bodies, and not addressing that has led to a handful of very close friends of mine now who find themselves single parenting as single fathers because they've lost their spouse. And someone who's been very vocal in this space has been Steve DeKeely of the Alexis Joy Foundation. And they went to 7 different providers, and one provider said to him, "Your wife is too good looking. She's not going to want to do anything to herself." So please make sure that you take women like this will try to asphyxiate themselves, or I forget the other one that he said. So, take the car keys away. Oh, or an overdose. Take any medications out of the house. And as because she was too pretty. These are the only ways that these women are going to hurt themselves, and instead he woke up to a tragedy 6 weeks after their child was born. And so we as a society are failing women, and we're failing our fathers and our partners and our families when that is the response to something that we know we have the answers to. These are very simple issues we can address, and we also see this in the substance use space with comorbidities. We have untreated mental health diagnoses, and women are self-medicating because we aren't giving them the voice that they need or the support services that should be available to say, "I am struggling," and it's okay. We don't need to put another pressure point on women when we are the ones being tasked with carrying the baby and delivering the baby and being the primary caregiver. When we take a look, even for working parents today, assuming that there's a traditional family unit, the mom is still taking up 70% of the overall household duties, and that includes if you're working full-time. And I think that for us to be able to give folks the ability to just exhale and say, hey, this is normal. Absolutely obtrusive thoughts, normal. OCD, normal. How can we help you? How can we help moms get back on their feet and what that good for society does? So a couple of things to think about early on a Friday morning. Again, we have an incredible panel here with Lisa Tremaine, with Valerie Plame, and Tiffany Farchione, and we're going to have
Valerie, speak. Yes, there's different ways to look at this. Valerie, again, could speak about so many of her life's stories that you can read in her book. But truly something that she brings to the table as out in the open as she has with her other issues is that being a mom. And she'll be able to give you some information on that. I just met her yesterday, she's an incredible friend, I consider already. I think she's just a bright spot with a very positive attitude who is willing and open to speak about this. And the mom's perspective is always where we need to start. I think it's the advocate. I think that it's lived experience. I think it's something that we need to listen to more. And so I will have the honor and privilege of passing the mic to you. Thank you very much, Valerie.
Thank you, Jamie. It's a pleasure to be here this morning because this is something I care about deeply. Thank you for having me.
Thank you.
I served my country as a covert CIA operations officer. I loved what I did. So proud to have been able to do that. My focus was on nuclear counterproliferation, which essentially means making sure the bad guys do not get nuclear weapons, whether those are rogue nation states or terrorists, black marketeers. That career ended rather abruptly because under the Bush administration in 2003. And I moved from Washington to where I am now in New Mexico and rebuilt my life. And a piece of that has always been a passion for a personal experience that I had. I had twins in 2000, January 2000. And despite the fact that I had some pretty extensive training with the CIA, I had traveled the world, I felt very much on top of my game. The fact was, when I brought home these teeny tiny babies at 4 and 5 pounds, I was completely undone. They brought me to my knees. But the strange thing was, I had no idea what was happening to me. I'm educated. These babies were absolutely wanted. They came late in my life, but I'm fortunate in that I am given a pretty sunny disposition. So I have never had any experience whatsoever with depression or anxiety or the related mood disorders around that. And I certainly had no idea that anything was related to childbirth. And so in those first really sleep-deprived weeks, as you point out, there's a reason we use sleep deprivation in torture scenarios, because it completely alters the very basis of who you are. Every new mother goes through it, and if you're lucky, you continue through it, your baby starts sleeping longer, and everyone gets adjusted. But for me, I think it was both the significant hormonal change as well as profound sleep deprivation that really triggered, within a week's time, a cascade of really increasingly frightening experiences. Again, not knowing what was happening made it all that much worse. I remember at one point stepping out to get the mail, perfectly normal activity. And I was about halfway to the mailbox, between the front door and the mailbox, and my knees sort of buckled out from under me, and I experienced what I now know was a panic attack. I didn't know, my body was not to be relied on. I didn't know what was going on. And of course, there's all the accompanying shame that goes with this, because at that very moment, all your friends and family are congratulating you on these beautiful, healthy babies, and how lucky you are. They know how much I wanted children, and the gifts were pouring in the door, and people are coming and making such a fuss. So when they ask, how are you doing? The only answer you could possibly give was, I'm doing great. Everything is wonderful. And that could not have been further from the truth. It was absolutely frightening, again, because I didn't have the knowledge. And after a couple weeks, and it went into a month or so, and I'm trying to breastfeed twins and all the things that are new and strange and different about it all, I'm sort of trying to figure out what's going on. What could possibly be going on? Because the books that I had next to my bed, all, how to get your child to sleep, how to, what you should be doing, they only talked, if at all, in passing, so briefly, on the baby blues. And many mothers do experience baby blues. And it was so, maybe it's changed, my kids are 19 now, but at the time, the tone was so patronizing in these books. Oh, you little thing, you'll get over it. And that's at least how I took it, but it certainly didn't describe what I was feeling, which was acute and dangerous and scary. I never thought that I would hurt my children, but I just, much like you thought, I thought if I could just go away, everything would be better. That's how I experienced it. So it wasn't until somewhere in the 3rd month or so that I finally identified, a friend suggested I might be experiencing postpartum depression, that I sought out help. And as you noted in your remarks, Jamie, how difficult that was. First of all, I went through the phone book, trying to find a therapist, phone book, how 2000, right? But how to find local therapists that dealt specifically in postpartum depression, because I thought that made sense. This is what I would, and first of all, most of them were saying, well, our first appointment is 6 weeks out, which you might as well say 6 years, like that. And I don't believe anyone asked me if I was going to hurt my children, because sometimes they do that as intake questions. But that's also extremely off-putting. I mean, I know the whole point is to make sure everyone stays safe, but it just felt, the whole process just felt embarrassing and demeaning. So I finally did find someone. I got on antidepressants, and over my children's first year, I came back into my own. And it was then that I realized this cannot continue. If I have every advantage, and I did maternal mental health issues do not discriminate. It doesn't matter if you're socioeconomic class, ethnicity, religion, anything, wherever you are in life, whatever you've done, you can feel it. And I was so surprised that living in Washington, D.C., as I was at that time, a major metropolitan area, had my children in one of the best hospitals on the East Coast, that no one had warned me and no one had told me about this, other than, I knew about SIDS and, put my child to sleep on their back, and breast milk is better than formula and so forth, but nothing about maternal mental health. So that started a long journey that I'm still on to today to try to advocate and educate. And we've made some strides, but a lot still needs to go, because there is still incredible stigma around, first of all, any mental health issue, but add in the part about the maternal part of it, which is supposed to be so joyous and fabulous that everything's, a little Hallmark card. And you really, you set yourself up for some real problems. So I can't wait to hear from both my co-panelists on what's in the future and what you're doing today. I'm a mom who gets to speak out on this because I have somewhat of a public profile, and it's meaningful to me. And if I can save one other mother from that deep abyss, and you pull them out and you go, this is not your new life, you will get over this, then it's all worth it. So thank you to my co-panelists today for being here, and thank you to Jamie.
Thank you so much.
No, that's yours.
I want to say thank you very much to Valerie for using your voice. Again, this discussion around maternal mental health complications should not be one of shame. It should not be shrouded and clouded in misunderstanding or lack of information. In taking a look at the years that the collective we have been focusing on this from a policy standpoint, which is again the reason why the Maternal Mental Health Leadership Alliance was formed. This is to continue to elevate this issue within policymakers' vantage point. I see a unique I, speaking on behalf of the larger we, see a unique opportunity for us to continue to elevate these issues. In the news, we see everyday information around maternal mortality, infant mortality, rising issues around substance use, mental health, etc. And here we are in 2019 where we women who are speaking on behalf of maternal mental health. So, in joking, in passing with our colleagues here and other colleagues in years past, you've got women's health, you've got mental health, and then you have women's mental health, and really trying to, beg for services. And that's not how we should be approaching this. We have evidence-based information to work with. We have, again, what this thing, it's new, it's called science, that we can that we can refer to. We have, yes, it is, it's fact-based. And we as women are constantly being faced with being questioned about, how do we really feel? Are you sure that's really what you're trying? And constant questioning. And Valerie, your story of just going out to the post box is something that we all had that experience, right?
I wish I knew that at the time.
And that is correct. You wish that you knew it.
I was so isolated, as we all were.
And why we feel in isolation when we could actually feel a sisterhood. And again, you brought up something yesterday that I also say, and why I in particular wanted to elevate this issue on the policy level. I was a white woman in the north of Boston with we have the best access to health care, with private insurance, and I couldn't find assistance. What in the heck does that say about my sisters that are in rural locations, that are in city locations, that are socioeconomically disadvantaged, that get kicked off Medicaid 60 days after they have the baby? Because, this is another study that they haven't come out with yet, but 60-day-old children do take care of themselves just fine. It's incredible. It is fact-based, right?
That's sarcasm.
That one was hashtag fake news. So, honestly, if you don't have the care provider and the mom there taking care of the baby, it then goes to a parent who then has to leave their job, or it goes to the state to have to take care of a child in foster care system and all. We literally could put whiteboards up here and just chart out all of the different scenarios that are just a cascade of this one point. And we have to be able to bake in services, and especially in socioeconomic disadvantaged populations that have dealt with racism, and in my own experience, having worked with some folks back in the Commonwealth of Massachusetts, being worried that my child is going to be taken away from me if we voice this concern. No, that's not how we deal with this. It's the same way that we're seeing substance use and keeping the mom and baby together during that recovery period. It's exactly the same. You give families the opportunity to keep the unit together, and that's the best thing for the baby. Because although my suspicious child at 7 days old, and you and I saying that if we just disappeared, the baby doesn't feel that way. We feel that way, and that's the unfortunate lies about this issue that we're talking about. The lies that our brain chemistry is sending off to us, and we've got to continue to elevate this issue for everybody involved. And if we take a break, let's take a look at the breakdown of the societal impact. Again, we have recommendations from Medicaid to screen for this, but we need to keep moms on in order to give them those services. In the Commonwealth of Massachusetts, we have a commission dedicated to postpartum, and we did have one of our community healthcare centers in Lynn, which is a coastal town, incredibly diverse location, had mere $50,000 grant to bake into their services with their pediatrician, their OBGYN healthcare provider, and they have an on-site perinatal psych. That is very unique.
Yeah, very.
And the screening period was, it elevated and spiked most 4 to 6 months out.
So that was an identifiable period of time. So if we are taking women off, 50% of all births in the United States are on Medicaid, and we take women off of that, if we don't have Medicaid expansion, we don't have services, then that in and of itself is problematic. We need to be able to have access for that coverage. So again, I hope if anyone is watching and they want to send us a comment or a question to Valerie, we're going to have Lisa speak and then Tiffany speak. I think at least I am very excited about and more science about this, where Lisa's going to give you facts and figures about what's happening at the Monmouth Medical Center in Jersey. So this is just a perspective on the East Coast. In Jersey itself, on a center that is dedicated, and it's very rare, dedicated to perinatal mental wellness. And we're gonna see things like we started with 5 women, and now we're up to 35. And you're gonna hear some incredible statistics. And again, if we also wanna talk about screening, maybe 30% of women will get screened for postpartum, meaning that there's a 70% out there that doesn't. And why?
Why?
I don't know.
It is, the Edinburgh's Carol is as easy as pie.
The
Everyone should
Edinburgh.
have one, right?
That's right.
It's not rocket science.
It really isn't rocket science, but and we'll go back to the fact, at least personally and professionally, when it comes to women's health, we're talking about
Yes.
perinatal mental health, So we had to that's why we had to bring the big guns in with the FDA. We brought science into the house. We're gonna talk about that. And we're gonna talk about dollars and facts and figures and human beings, because those are quantifiable. And Valerie's story here in DC, and my story in Boston, etc., these are real lived truths. And let us continue to elevate our voices during Maternal Mental Health Week, Maternal Health Month, and Mental Health Month. That's a trifecta, folks, okay? Use your use your social media power, use your power to the people, and use your voice in this. So I will have Lisa Tremaine, the founder of the Bloom Foundation, as well as, what's your position and title at Barnabas?
I'm the founder and director of the Maternal to Wellness program.
Yes, so she does things on a real small scale. She's the founder and director of the Maternal Mental Health Program. Thank you very much, Lisa.
Thank you, Jamie, and thank you, and Val, even meeting you and then hearing your story again, I'd like to apologize for everyone who failed you at every step, and how sad it is that you couldn't find help, again, being in an area
Where it
you
should have.
get help. Yeah, and really, we should be able to expect help in any corner or in the middle of the United States, so let's hope we can get there. So my name is Lisa Tremaine, and just like Jamie and just like Valerie, I am also a survivor of what we now know is perinatal mood and anxiety disorders. Back when I had my kids, right before you had your twins, I suffered from, and I do this list because it is preventable. I had risk factor after risk factor after risk factor, and if someone had at any point been like, wow, she's 6 years of infertility, she's pregnant with quadruplets, she is a nurse. Nurse is being, one of them. Social workers, teachers, we suffer more than anybody.
Right.
Interesting.
Because we're all helpers and empaths. If you have a prior history of a miscarriage, if you have a prior history of anxiety or depression. So it's very funny with women. Men will say they've had depression and their dads had it. Women will be like, no. And you'll be like, never had anything in your whole life. In high school, in high school, I was, my mom used to say I was a worrier. And I always say, well, the official diagnosis for worrying is anxiety. So we're able to, from this center, pull facts and figures like crazy. So 82 out of 100 patients had a prior history of anxiety. So I don't know, what if we just said to an OB patient, have you ever had a experience with anxiety? We could start marking these people. So I had triplets on Christmas and was told that it was the best gift. I must be the happiest mother ever, and go enjoy that. And again, was dismayed that I was not able to care for them being a nurse. I had been in NICU and labor delivery and postpartum, and I was like, cool, I'll just run it like I do work. Never factoring in that you don't sleep, and the sleep deprivation. Yep, you said it too. I think the sleep deprivation being so profound, the hormones of that many babies, if you're breastfeeding, if you're not, and then add in a history. It's just a perfect storm. Yep. So with that being said, I made it through 5 years later without medication, without any help, and really, you know, as we say in paying it forward in our children, I continually try to make up for what I'm sure were just horrifying years for them. And they seem pretty good, but it is just for all you ever wanted and what you wanted to be, to then not be what you thought you were capable of being is absolutely devastating. And being in the maternal health field. So flash forward, everything's golden. I go back to work as a nurse, and my new job is now doing childbirth education. And because that will give us money for all these mouths to feed. And I'm seeing all these people afterwards at new moms groups, and I'm noticing that they are feeling, their faces look like I felt. So I kind of pulled them all aside, and they just had their kids, and we were using words: overwhelmed, anxious, I feel like a failure, I failed at birth, breastfeeding, pick all the things. And I proposed to have a new group just for these moms, so that they weren't being put back in a place where the happy moms were over-happying them and were making them feel worse. So that was in 2012, and by 2014 I had been referring them out for help, and the group had grown and grown and grown on its own into a really unmanageable number. And then went to the hospital, to Monmouth, and to new business development, and showed them my numbers. I love numbers, and showed them how many people I had over the 2 years, how many people I'd referred out for treatment, and how much money they had lost in letting me do that. I got a program the next year, and started in the basement. I'm not in the hospital, and I'm directly under OB. That was the other thing. So that it's not a psychiatrist problem. It doesn't bring in nothing against psychiatry or behavioral health, but if women are already stigmatizing themselves and they're not going to accept help, and they're going to have that shroud, if I can pull it away a little bit, and equalize this to gestational diabetes or to preeclampsia, and say this is just an OB complication.
It's a thing.
And now they are coming in. So I think there are, I made notes as you were talking because it was so, it even brought up more. The program has been in existence since 2015. Our first year, we had 505 patient visits. At the end of last year, we had 3,503 patient visits. We are one program smack in the middle of New Jersey. And New Jersey being what I consider kind of a metropolitan area. And these amazing women, families, mother-in-laws, fathers, partners, drive up to 90 minutes away just to get here. And when they do, you know, and when they call, I always say, if you had cancer, you'd go to Sloan. I would. I'd want to go there. The first treatment is the best treatment. So if I can bring them to us, and we're a pure multidisciplinary center, so everything you need is in one place. This is not rocket science either. You know, if I made it as I grew along and thought, well, this is what we need next, and then to take this model and be able to produce all these numbers, there's no reason this can't be everywhere and shouldn't be everywhere. Because if you're screening moms in Albuquerque, who's treating them?
Right.
So I don't blame the OB who's saying, if I screen them, where do I send them? Now he's liable, and there's no proper treatment.
Approach.
It's a whole mind-body thing. So we are hoping, you know, to get more in New Jersey, but we'll see what happens. We're able to say that moms who come in within 1 month of treatment lowered their Edinburgh scores by over 10 points, putting them from the high-risk category down to below risk. And these are moms who, you know, I go out and say right away when they come, welcome home, you're here, you're safe. You can answer this, no one's gonna take your child, and no one's gonna call the police. So we feel we get really good answers on the Edinburgh. The Edinburgh, you know, is more of a depression scale and was made many years ago, but it's the only validated tool we have right now. And then with the moms coming in, being able to say it is temporary, it is treatable. It's 1 out of 5 pregnant and new women. We deal with pregnant women, we deal with postpartum women. We see 20 to 50 moms a day. We get 13 new calls a day. We have to hire people every month. You cannot keep up. And just like you said, I will never put someone out 6 weeks. So we triage all the intakes. So there's 2 full-time nurses doing intakes all day. And then we just decide who we're gonna move out of tomorrow's calendar to put Jamie in, because Jamie needs to be seen tomorrow. So no mom ever waits. We have a calendar of events for mom and baby. We're a full mom and baby program. So mom, baby, we have service dogs come in all day, every day. There is group therapies, individual therapies, medication management, evaluation. We bring in grandmas to rock a baby. We have safe sitter girls in the summer that come in and play with the babies. We do infant massage. We have couples therapy. We have a loss group, a pregnancy group. We started out in 1 room. We're now in 8. We cannot keep up because we're it. I know. And I don't understand why this is falling on deaf ears. And Monmouth, praise Monmouth. I mean, they literally are like, just give her what she wants. When I left, was getting 2 more offices.
Is this only for Monmouth patients?
No, we treat all the hospitals, anybody.
Okay,
Yep, you don't have to have delivered there at
okay.
all.
That's nice.
And there are OBs who, because I was an OB nurse, they have my number, so they'll text me, and no matter where I am, they're like, Lisa, I have a mom. I'm like, I'm in Arizona. And so then they tell me what's going on, and we go to the floor if we can. It is just, the number of women that come in, like our strollers make a fire hazard. They have a million times come down and been like, we have to move the strollers out. We've ruined the parking in the hospital. So it is the field of dreams. If you build it, they will come. And the Bloom Foundation, as you said, we are there all about how you're all about policy. We're all about, we've done this, we've invented this wheel, we've perfected the wheel, we know where we went wrong and where we went right. So please let me bring it to your hospital. Please let us show you all the people who did the right things, how easily you can do it. And then all the moms you're screening, you have treatment for it. You don't have to wonder where they are, what they're doing. You have a responsibility because it will affect the children. I see the moms now whose moms had it and they weren't treated, and how broken they are and how much more broken they are. And then they go on to have kids, and we're helping them. And we know how real suicide is because we talk about it every day.
If anyone who is watching, or for me, how do we contact you to see if in our local hospitals, for instance, I live in Santa Fe, New Mexico, and we have a pretty good, now 2 hospitals. How can I find you to see if there are hospitals might be open to having the program?
Oh, thank you, and I love you. Really just our common address is info@thebloomfoundation.org or directly Lisa I love getting many thousands of emails, @thebloomfoundation.org. We have a 3-day hospital training program to take you from soup to nuts. Literally, we'll get you up and get you going in any phase you want, and we'll help in any way just to get this going. Then we even came up with much that there was the baby-friendly initiative. Did I roll my eyes? Because I felt like I might have rolled my eyes. We have come up with criteria for hospitals, OBs, midwives, pediatricians to meet that are completely attainable to get a maternal mental health friendly certification. So that someone going there can say, oh, this hospital cares about my whole being, not just my baby. And it will designate that it's a safe place to be, whether it's for your mind or your body. And the other thing is how many opportunities we have to be in touch with women and to screen them. Childbirth education, is anyone talking about this in childbirth education so that the dads and the partners hear it? At the OB office, if you're having a 4-hour glucose test, you can fill out a couple forms while you're there at 20 weeks, and then they know they have somewhere to refer. And I really do get that, but if we could build this out, then every one of these would just be a fax referral over, and that whole team, like we do, would follow up. It all works. Pediatricians are now being told that they have to do it, and again, are even farther step out, right? So their baby, the patient is the baby, and they're willing to do it, but where are they referring? And you really just can't blame them. And the feeling, like you said, of community, and seeing these hundreds of women all the time, every day, they all say the exact same thing. I thought this was how motherhood was supposed to feel. I am completely alone and isolated, and I'm a failure. And so by bringing those women together, I make shirts that say class of. So like the first year I had class of 2015, and now we have, and they just stay friends. You see the friendships in the village and the tribe that we have lost coming back together. Yeah, and also calling it the wrong name doesn't help. Postpartum depression is a misnomer. People say I didn't call to get treatment because I wasn't sad. I didn't feel like hurting my baby. I didn't feel like hurting myself, so I didn't call. And they call when they're 6 months. That's when everybody gives up. When everybody has just had enough and they can't make it anymore. And it could be, you know, having this program that we now know works, and we now know for hospitals makes money after 6 months also.
Wow.
Yes.
Can you speak to that part as well as the insurance piece on how that is addressed? Because the general concern is exactly what you just said, we're going to lose money and insurance won't be accepted.
So I'm a part of a large hospital system, as all, you know, all hospitals are becoming systems. I don't think we're anything unique or different. We take the military insurance, which I know is a huge thing. We even get that. Medicaid, no problem. Private insurance companies, no problem. So now, can I speak to the rate at which they're reimbursed? You know, every hospital is different, but I can tell you that we bill over $150,000 a month in our patients right now. We saw 135 individual patients just last month. Yeah, it is astounding. And when you extrapolate it all out and where it could be, you know, if you had these centers an hour away, and they all were already, there's the formula, and we know it works, so why don't we just put it out there? If legislatures are passing bills in California, what are they gonna do? They have 250 birthing hospitals, and they have to have it done by January 2020. How are they gonna pull that off? And now women know, right? Because we all turn to Google. So it's, where am I going for help? And you should not go to someone who doesn't know what they're doing. So, you know, we can help with training, getting the right people, starting the community, and getting real hospital programs in there that can help someone. And by having the medication evaluation, which is also a really huge part of it, and being able to follow women, not having to find a psychiatrist where they have to wait 3 months or 6 months, is life-changing. And now with Zulresso being available, I mean, that just changes the whole scope, so that they're gonna need even more centers, because you can't just treat a mom and then be off with you after that 60 hours. Good luck. You know, we have a responsibility to treat what happened and what her PTSD or birth trauma was about, feeling that and getting that. So the drug will do everything, but then we have to take care of the rest of her. And you're not just saving a mom, you're saving the whole family. Did I cover all my stuff?
Oh my gosh, no, but it's never,
I know.
there's a lot of information to be covering. And that's just one center in, is it
Long Branch,
Long Branch, New Jersey?
Mm-hmm.
And the formula that we just heard with that, Lisa, thank you so much for speaking to that, really is an evidence-based model of care where we've seen, yeah, here's my challenge with the math, I'm a policy person. I mean, if you went from 50 to 3,
Oh, I had to get, no, my husband's in math, so
Okay.
we grew 91%.
91% growth in a 4-year period. So they
Each year.
started
Yep.
with 500 and ended up with 3,500 clients. And that is spectacular in and of itself, that women felt comfortable, or the family members knew that there were services available. And we're seeing this sort of model with what you've done. Thank you for knowing what you didn't receive and how to accommodate that for families. Because this thing called postpartum depression, which it is not, was also called milk madness. That was a favorite of mine. That's from the 1850s. Again, it's got, you know, we get this, we get that, we get all these things going on. Okay, so you know, it's because we're women. Who was the woman that was married to Woody? Thank you, Mia Farrow. Jeopardy facts. So Mia Farrow did the Louis Gates ancestry thing there on PBS, and her family came from Australia. She didn't meet her grandmother, and they went and found her grandmother's records, and her grandmother had been admitted to like a respite center after she had given birth to her dad because she had milk madness, and eventually she died. And that is postpartum depression. We have that also famous book, The Yellow Wallpaper.
Yes,
Okay,
I talk about that too.
I will
That was
never,
the 1800s.
I will never put yellow wallpaper in my house.
No.
Okay, because they literally like, oh, you're tired. We're just gonna put you in this room. You just need to rest. You know, we're gonna take the baby away from you, which is not
Lock you up
the
here.
goal, right? We're gonna put you in this room. Some women need to have that break from the baby to get themselves well.
Some women don't want the baby to be a part of them, they just want to feel well. And we have to be able to address individually these women. But the historic aspect of this is very evident in the way that we have written these tales. We are now in 2019 where people move to different cities away from their families. They're not with that family unit. We have families that aren't a traditional family unit anymore either. We don't have the grandma making the sauce and meatballs on the floor while you're living on the third floor of the triple decker. You know, those days are over. There is more access to services in a city composition. Had I been in Boston during the time of continual 6 feet snowstorms in January of 2010, when you couldn't get out of the house after having an emergency cesarean, maybe if I could have just gotten out and walked around, maybe I would have felt better. But when you're in just even a suburban location, never mind a rural location, where your only point of access maybe 2 hours away, we need to be able to have access through social media, through video, through different capabilities as well. We're seeing that there are mental health accessibilities now that are through Skype, through FaceTime, etc. And this also has allowed some normalcy and also breaking down that isolation. You might be in a rural location, but you can actually speak to another person and be able to connect through Facebook with these support models. So again, as far as the policy piece goes, which is where the Maternal Mental Health Leadership Alliance, I'd like to speak to my board as well. We have amazing folks on the board such as Adrian Griffin, Postpartum Support Virginia founder and executive director, who is live streaming this right now. I'm paying her a lot of money to do that. And it's all in love and hugs. And so the passion that Adrian brought to Postpartum Support Virginia is part of why I wanted to harness her expertise and understanding about this issue. We have Katie Schubert of Society of Maternal Fetal Medicine. I can't express enough the policy prowess that she brings to the table. We have James Gelfand, who is Executive Vice President. I can't think of the facility at this point, but he was my March of Dimes buddy who helped us pass the Bringing Postpartum Depression Out of the Shadows Act of 2015. I'd also, again, like to speak to Catherine Clark, former member Ryan Costello, Ed Markey, Jill Brandt introduced that bill, former member Dean Hella, and Shelley Moore Capito in West Virginia. This is an issue that she saw with her teen pregnancy rates. The teens are not immune to this, especially when we are not affording teens the ability to be looked at as a full parent if they've birthed at a younger age. There's discrimination within that as well. And there are, again, the comorbidities with the substance use as well, and really being able to identify and parse out the mental health aspects of this. From a policy standpoint, right now, we have a lot of different federal legislation that's in the hopper to be considered. We have the Mamas Act with Robin Kelly. We have the Moms Act with Gillibrand. We have the Mommies Act that's waiting to be reintroduced with Cory Booker. I know that we're on our second year of asking for full funding for the maternal mental health grants that were disseminated through SAMHSA. And it went to 7 different states. It was approximately $650,000 that was out of a $5 million grant fund for a period of 5 years. And that went to states that applied to the government that said, we're gonna have an educational component, a screening component, and a support component, because again, you can't say, you totally screened positive. You're like in the 20s on this screening. Good luck. It doesn't work that way. And that is part of where folks can step up to the table with what you were just speaking about, Lisa, what we're gonna hear with the FDA with the novel pharmaceutical approach to postpartum depression, and what Valerie and I have spoken of firsthand, having experienced this. If we normalize this, if we speak about it, if we have access points, if we share our stories, then we take the boogeyman out of the conversation, and it no longer becomes this scary situation that we don't talk about, it becomes real. My ongoing joke is the baby that's on the side of the Pampers box. Now, I only had one. You had three and two. Again, that's another conversation for another time. It's another briefing on moms of multiples. I do think that the sleeping baby on the side of the diapers box is one of the biggest disservices that anyone could possibly put out there for public relations. Yes, the baby will sleep with the clean diaper, and that's a whole other issue of accessibility to diapers and the costs. But the child is okay. It is okay to show a screaming child with the clean diaper on the side of that box. That really is something that's the truth. We need to have our truth in motherhood, and it does not mean anything about not wanting that child. I wanted nothing more than to have my children, and I'm thrilled to be able to have the opportunity to have a phenomenal relationship with them today. And had there been access to pharmacological remedies for myself that would have worked much better, I found myself on a prescription of Zoloft that inevitably, I thought I was in early menopause. I was sweating so badly and had insomnia, which was exactly the opposite of what I needed. Okay? I couldn't sleep to begin with. And then that gave me, then I was sweaty and awake. It was not what I needed. And then when trying to come off of that, I felt like a zombie. And that was my own experience. You know, every single body's chemistry is different, and there are going to be pros and cons to everything for everyone, but that was not the right pharmacological for me, pharmaceutical for me rather. And we need to be able to continue to move forward in the direction of accessibility for treatment. And again, as far as mental health goes, this is the only preventable and treatable mental health complication that we have. I want to speak quickly to the Mathematica report before we bring Dr. Tiffany Fascioni. Is it Fascione or Fascioni? Fascioni, see? I grew up with Italians and I'm married to one. So I do want to say on the Mathematica report that they have what's called a conceptual model of how untreated PMADs influence maternal, child, and societal outcomes. And when we take a look at the mom, well, I'll speak about that and go to the child and then pass the mic to Dr. Fascio. Higher work absenteeism and presentism, lower labor force participation, increased likelihood of suicide. And again, there is no cost to put on that for loss of life. Increased risk of worse maternal health, obstetric and general. That bleeds into the child because again, you don't separate the child from the mom. We have increased risk of low birth weight or preterm if the mom is depressed, lower likelihood of being breastfed if that's something that a mom chooses to do and is successful with that, which you don't have to choose. There's this thing called a bottle that works just fine. And also allows the partner to interact with that component of taking care of the child. Increased risk of sudden infant death syndrome. That is very eye-opening when we think about that, because that was part of the baby on the back PR, where we should be also speaking about taking care of the mom and the baby on the back. Increased risk of behavioral and developmental disorders, which is something that is a universal issue here in our national landscape, especially with education. An increased likelihood of worse child health, injuries, asthma, preventative visits, and obesity. And that those all lead to increased healthcare costs, income loss and reduced economic output, and increased use of public services. So there again is the health to dollars component of this, and really taking a look at the family wellness component. And we are going to hear from Dr. Tiffany Fascioni on the novel drug treatment, the first and only drug treatment that is available to address certain aspects of what we're talking about with maternal mental health. So thank you very much for being here, Acting Director at the FDA. Thank you.
So just to be very, very clear, because FDA is a big place, we have our own zip code actually. So I'm the acting director of the Division of Psychiatry Products, so it's a small component of the big picture. But I do want to say thank you to my fellow panelists and to Jamie for doing this today, because this is really such an important issue in order to address. And I'm so glad to be able to say that, you know, my division has now approved the first treatment that is specifically aimed at treating postpartum depression. This was a huge deal, and you know, it's made national press for a reason, because this is a major problem that has been under-addressed and even under-recognized for far too long. So at my work, day to day, basically what we do in the Division of Psychiatry Products is we are responsible for reviewing the safety and the efficacy of new drugs that are intended to treat psychiatric disorders. So everything from ADHD and anxiety to schizophrenia, we have the whole gamut. And so postpartum depression falls into that realm. Prior to this particular drug coming to our division, there really wasn't a lot of drug development in this space. You know, it was sort of conceptualized that postpartum depression was just an episode of major depression that happened to occur in the postpartum period. That's the way it's described in the Diagnostic and Statistical Manual, Mental Disorders. It's the way that, you know, all of the diagnostic criteria are the same, except for, you know, it happens at this time. And so, you know, the treatment was always just, well, we can use all the same antidepressants that we use for any other version of depression. And when it would come to us from the regulatory perspective, we would look at that and we would say, okay, well, if you have a drug that is, you know, that you're trying to target postpartum depression, why won't it just treat regular old depression? And we would say, well, look at the bigger picture. In this particular case, this company came to us, and the drug is I don't use brand names, but the generic name is brexanolone. So the company came to us and they said, you know, this is a synthetic version of a naturally occurring hormone, and we believe that the mechanism has something to do with the shift in hormone levels that happen immediately after birth, and that's why we think that our drug is going to work in this particular population. We don't even think it will necessarily work in just run-of-the-mill depression. And we said, okay, well, now you have a reasonable sort of scientific justification for looking in this specific population, and that's why we went ahead and let them pursue this narrower indication. The other thing that's really unique about this product is that it's not a chronic treatment. It is a IV infusion that is given over the course of about 3 days. It's a 60-hour infusion, so you do have to stay overnight and you have to be monitored and all of these things. But once that infusion is done, your treatment is done, at least medication-wise. So we thought, okay, well, that's also unique and different, but you know, just because your scores on a depression rating scale are better at the end of that 3-day infusion, what happens when you go home? So we made them look also 30 days out to say, is this a sustainable improvement? And as it turns out, in 2 different studies, the first study, they looked at folks with severe postpartum depression, and folks, the scores on their depression rating scale improved. The people in the placebo group, it didn't get as much better. So you saw this nice statistical difference right there at the 60-hour mark, so as the infusion was ending. And then if you look 30 days later, they were still better. The other study where they looked at folks with moderate postpartum depression, you still saw that same difference at 60 hours. You didn't see a statistical difference at the end of 30 days anymore, but that wasn't because the people who received drug had gotten worse. It was because the people who didn't get it kind of slowly got better and met them where they were. So, but the drug is indicated from moderate to severe because it did work in both populations. But it does have some safety issues associated with it, and the biggest issue is about 4% of the people in the studies just randomly passed out, like sudden loss of consciousness. So and there wasn't anything that we could do when we looked at, you know, demographic factors or other risk factors or anything. We couldn't figure out what it was about those particular patients that made them prone to passing out. So since it wasn't something we could predict, then we had to figure out a way to manage the risk, because we said this is a highly effective medication. What can we do to make it so that it can be administered safely? And that's where the FDA has authority to mandate things called risk evaluation mitigation strategies, or REMS. And so we have a REMS for this product where it has to be given in a setting where the patient can be monitored and where they can get pulse oximetry, so that way, you know, when people passed out in the studies, they immediately stopped the infusion. If this happened at home, we don't know what would happen. So we make sure that way, if they have the pulse ox, if this, you know, passing out happens while the person's already asleep, and if they get hypoxic, you can tell, that kind of thing. It was just an abundance of caution, because we don't know what would happen. And so, you know, they have to be in this safe environment and everything. You can't be the primary caretaker of your infant when you're getting the infusion, because if you are one of those people who happens to randomly pass out, you don't want to drop your baby. That would be bad. But, you know, at the end of the day, now we have a medication that is approved to treat a serious illness and that works quickly, and that the benefits are sustained over time. So this is something that actually qualified for what we call a breakthrough therapy designation, which allowed us to bring it to market more quickly than it otherwise would have been. So it got a shorter review clock. Basically, they have more interaction with the agency during the development program to help facilitate that. But it's a whole new world. I mean, it's actually a very exciting time to be in psychiatry, because, you know, up until very recently, the most exciting thing that had happened in psychiatry was Prozac 30 years ago, or fluoxetine, because I don't use brain. But you know, and now we have the first rapid-acting antidepressant treatments. So we have one that is more general rapid-acting antidepressant, and then we have this one that is specific to postpartum depression. 2 different mechanisms of action, everything, but they both work quickly. And so that makes it very exciting, because now, with new and better treatments available, I would hope that more people would seek treatment, because you know, the stigma associated with mental health is really problematic when it comes to people seeking treatment. I mean, you said that you felt like you were all alone, like nobody had experienced this before. You said that, you know, when you bring these women together, now it's like, okay, finally they feel like somebody understands what's happening, because people don't talk about this. My own, I don't have children, so I've never experienced postpartum depression, but my own sister-in-law, who is the mother to my 2 favorite people in the whole world, she experienced postpartum depression after my first nephew was born, and I didn't even know until she was getting ready to have my second nephew, and when she talked about how she was afraid she would go through that again. And, you know, I'm a psychiatrist, my brother's a psychologist, and my sister-in-law, I had no idea, because people don't talk about it, because you're supposed to be in the happiest part of your life. You just had a beautiful child, and my nephews are beautiful, I'm just gonna say. But, you know, she just had the most beautiful baby in the world, and she didn't feel joy. And so, you know, then you feel ashamed, and you don't want to talk about it, and all of those things, and it's this downward spiral. So now that with more treatments, hopefully there will be more recognition, and then we can, you know, when we approve drugs at FDA, we look at the benefits and the risks for that particular patient who is receiving that particular drug. You know, we don't necessarily have in our benefit risk assessment a section where we talk about how that patient's experience affects but I'm a child psychiatrist, so this is something that I think about, and, you know, taking my FDA hat off for a minute and just thinking about my child psychiatry experience, I know that the downstream effects of maternal depression end up being, you know, show up in my office as a child psychiatrist, that, you know, you have issues with mood disorders and aggression and all of these things. So I would hope that if we do a better job of treating maternal mental health, that will improve child mental health, and then the downstream effects of that are just, you know, better for everybody. Not to get really hyperbolic, but you know, it's a very exciting opportunity to be able to do something where, you know, instead of giving someone a medication that you hope might help a little bit in 4 or 6 weeks, you can know within 3 days whether or not this worked. And it's not going to work for everybody. You know, it didn't work for everyone in the studies, but it statistically worked better than the placebo. And people actually reached remission, they reached, you know, they have response criteria, they did very well. So if now that we have these treatments available, hopefully this will lead to better awareness, better understanding. Even if people don't necessarily qualify for this treatment, or they can't, you know, take 3 days out of their lives to go for an infusion, at least they can know enough to seek help, and that alone hopefully will make some difference.
Doctor, question for you
Yes.
in regards to this space on postpartum depression, and you speaking about how since the generic labeling of Prozac some 30 years ago was the last revolutionary step forward into psychiatric challenges, does this excite a conversation within the FDA around continued development or partnership? Like, where does the FDA go when you find a new novel drug approach to something within the psychiatric space? Does that create additional conversations for what that will look like future forward?
Well, so we don't do the drug development. We're more of a receiver kind of organization, but hopefully what this means is if the companies who are developing these drugs can see that that there is space for these medications and for these approvals, that they will try to take some more creative approaches, take more risks to try to you know, find new mechanisms, new treatments, new approaches, and bring them to us, because we're certainly willing to work with companies and say, you know, if this one looks really interesting, but you've got X, Y, and Z problem, if you do this study in this way, you know, we'll know how to label it. It's always a back and forth between the agency and the companies in order to get to that end result, which is an approved drug with a label that tells physicians how to prescribe it safely. But yeah, I mean, we're certainly open for business if they want to bring us any new products.
That's great. Great. Thank you.
Thank you.
Thank you so much to this panel here. The flow conversation, just the easy conversation that we've all been able to share back and forth, speaks to you know, women. We speak to each other and we're able to communicate, and I think that is a really big part of this messaging here, is being able to communicate and using our voices. I don't know if there's any questions that have come in, or any viewers who have a discussion point around this. This live feed will be captured after this session concludes on Facebook, and I want to be able to disseminate that, because I think going into Maternal Mental Health Week, this sort of discussion and this sort of panel allows people to take their time and watch this information, as far as a mom who might be dealing with this, has dealt with it, is a practitioner looking to speak to what you're talking about here, having services. How are you doing that? What did the FDA see within this particular product that excited them, and obviously went through the rigors of what the FDA was looking for. I think from a policy perspective, that this bodes an entire conversation from the local, state, and national level for us to continue the need to emphasize the health and wellness of women, especially when it comes to care providers. I know Jersey in particular, we have such esteemed congressional members as the current chair of the Energy and Commerce Committee with Frank Pallone. We have champions within the First Lady of Jersey, Christine Murphy, former champions, Mary Jo Cody. We need to continue to talk about this, and we need to look for dollars and cents to create public-private partnerships. We need to be able to roll out pilot programming around what we see here at the Monmouth Medical Center with the maternal health program. We need to be able to look at the cost savings aspect of that when we take a look at a $14.2 billion price tag to the societal impact, and we take a look at a novel treatment such as Zelresso, which did have some questions around the price tag. I would beg to differ to say that a company such as Sage Therapeutics that developed that hasn't been working with the folks that need to be holding the insurance side of this to say that a $30,000, not covered price tag is worth more than the life of the mom itself. And there's a lot to parse out of that. I know in particular, had there been the opportunity for me to take an intravenous and have my family come see me, I probably would have really righted the ship quicker than it had. I think that would have been an incredible opportunity to have had something that was specifically for postpartum anxiety and depression, where with the other antidepressants, it really is a little bit of a shot in the dark in what's going to work under what. To our audience members, are there any questions here? Yes.
I have a question for Tiffany, actually. You know, you noted that the FDA doesn't obviously do research. They evaluate research. However, it is striking to me that we have 3.5 billion women, approximately. Many of them will give birth at some point in their lives. How do we encourage the development of research in this field, let alone you're a psychiatrist as well, let alone in mental illness? It was striking to me that you say your department's a very small department within the FDA, yet we know there's 3.5 billion women out there that need help.
I don't know the answer to that, to be honest. We don't have a lot of tools in our toolbox in order to encourage development in specific areas. I mean, for instance, for pediatric drug development, we have things like the Pediatric Research Equity Act or the Best Pharmaceuticals in Children Act that we can either encourage or mandate studies in children, which actually reminds me that for Brexanolone, we have a post-marketing requirement to look at postpartum depression in adolescents, so 15 to 18, because we know teenagers get pregnant and have postpartum depression too. But it's very limited in terms of what we can actually do to either mandate or encourage things. Orphan drugs is another area where we can encourage people to look at rare diseases, but it's small toolbox.
I have one small question or one small statement as a male to the part of our challenge. And that is, it's my deep belief that if you take a look at the people who enact policy, it's a male dominated. If you take a look at the medical profession, it's male dominated. And my encouragement is we need to get more women in our elected offices to develop policy that pushes this envelope forward about this forgotten population that is half of us.
I want to thank you, Joe, for your statement. I think when we do take a look at that, it really does speak to why we saw the first time a federal policy get pushed through not pushed through, it was eagerly sought out in regards to postpartum. And I'll speak to that very briefly, with members, female members coming into Congress, with a congressional representative such as Catherine Clark, who is a mom of 3, and who knows from the state that she comes from, again, Commonwealth of Massachusetts has a postpartum commission, we have pilot programs, we have evidence-based treatment model with the Massachusetts Child Psychiatry Access Project for Moms. That's a mouthful, it's MCPAP for Moms, which is an online access for maternal mental health psychiatry. And taking a look at something that's underdiagnosed, it is 1 in 5. The government figures are getting it down to 1 in 9. We as women are 53% of the population, and I don't know what that percentage is offhand of childbearing age, say 15 to 18 and then the 18 to 45. I'm gonna guess that it represents a lot. It's another reason why, African American girlfriends of mine saying, oh my God, I'm scared to death, I'm gonna die when I give birth. And it's one of these things where, if that's the bottom line, like common denominator discussion we're having for women, we best need to rise up and change some things. We have representatives like Lauren Underwood, who's a nurse, came from Connecticut. She just unveiled the Black Maternal Health Caucus. I'll go back to Catherine Clark and champions who have been around the way, and this is again bipartisan. Lucille Roybal-Allard from California, Jamie Herrera Butler from Washington State. They had what's called the Congressional Maternity Care Caucus. But yes, did the Congressional Maternity Care Caucus exist when it was all male? The answer is no. And so we're seeing many maternity care bills and women's health bills coming to the forefront because of the fact that representation matters. Representation matters on the issues that are sometimes not even looked at, because when you don't have someone that looks like you, comes from where you are coming from, understands the issues that you're dealing with, they're not going to be addressed. And this is also something that we've seen with the Black Caucus's Brain Trust. There's a caucus around Black women and girls as well. These are ongoing conversations that need to be had. We have representatives like Sharice Davis and Debbie Haaland, who are Native American representatives, and Debbie Haaland, is it Haaland?
Deb Holland.
Deb Haaland, thank you.
Holland.
Who was from New Mexico.
She is,
correct?
she's the first Native American.
First Native American.
Female representative.
Because that's normal. And I'm only saying that because that's clearly where our Native ancestors are coming from here. But she has been a very vocal component around the health needs of Native American women. Because again, when we take a look statistically, if African American women, Latina women are suffering 1 in 3 with postpartum anxiety and mood disorders, and so our Native tribes and Alaskan tribes and Pacific Islanders, representation matters. So I appreciate the point at hand. There's a huge opportunity to move forward on this. So I want to say thank you again to the panel here, and we'll have this up and running on Facebook. And thank you, Adrian, for your assistance. Great job.